Hello, I'm Wilfredo Seda, and welcome to Piénsalo Bien, Think It Over. This program explores strategies for education, prevention, and treatment on drug abuse. We hear of the opioid heroin epidemic here in Lancaster County as well as in other counties in Pennsylvania. We are told that the overdose deaths will continue to rise this year. Today we want to learn the medical and public policy implications of this scenario here in Pennsylvania. With me via Skype is Dr. Rachel Levine, Physician General of the Commonwealth of Pennsylvania. Dr. Levine has a long career in medicine. She graduated from Tulane University School of Medicine in 1987. Throughout her career, her focus has been pediatrics and adolescent medicine. She came to Pennsylvania in 1993, continuing her work in these specialties and enhanced services for youth at Penn State Hershey Medical Center, initiating the Division of Pediatric Ambulatory Services and Adolescent Medicine. In addition, she has a distinguished career in academia. Dr. Levine, thank you for being with me today.
Hello, I'm very pleased to be here. Thank you for inviting me.
Let's start out. What is the role of the Physician General of Pennsylvania?
Well, so as the Physician General, I am a member of Governor Wolf's cabinet, and I advise the governor and the administration and the Secretary of Health on medical issues and public health issues. And one of the main issues, as you pointed out, that I have been working on is the opioid crisis.
Mm-hmm. Well, moving on the opioid crisis, from your perspective, how did we get to this point in Pennsylvania and really in the rest of the country?
Mm-hmm. So as you've pointed out, the opioid crisis is really the biggest public health issue that we have in Pennsylvania, and you could argue throughout the nation. And the cause of this is very complex. It really is a story that is over 20 years in the making, and is the perfect storm of different factors. The first was the emphasis on assessing and treating pain that was recommended and then required by federal regulatory authorities in the 90s and the early 2000s. So that includes the Center for Medicare and Medicaid Services, as well as the Joint Commission, which helps regulate hospitals. And so healthcare professionals started to do a much more robust job assessing and treating pain, and that was acute pain and chronic pain. And it included not only severe pain, but rather mild to moderate pain, with unfortunately the expectation that somehow we were going to eradicate pain. At the same time, there was the development of extremely powerful, long-acting opioid pain medications developed by pharmaceutical companies that were unfortunately marketed to healthcare professionals that they would not be addictive to patients with pain. And as we know now, that has proven to be completely false, and they are very addictive to patients with pain. The third piece of the puzzle has been the influx of very cheap, powerful, and plentiful heroin into the United States over the last 5 to 7 years. And you put all of those factors together, and they have exploded into the opioid, heroin, and overdose crisis that we see today.
Doctor, in the last year or so, we've heard the chemical fentanyl into the mix as well. Talk to us, what is that and how does that worsen the scenario?
Sure. So you are entirely correct. One of the biggest public health dangers that we're facing in the midst of this crisis is the influx of fentanyl compounds and synthetic opioids. So fentanyl, when it's used as a medicine, excuse me, is a very powerful opioid. Fentanyl is actually about 50 to 100 times more powerful than morphine, and it's used with patients with very severe acute or chronic pain. So what we're seeing, however, is artificially made fentanyl, primarily from Asia, and then used by the drug dealers to cut the heroin because it's so strong. So it's in a powder, it's very cheap to produce, and it's used to cut the heroin, and it makes it very, very powerful. And so we are seeing a significant increase of deaths in Pennsylvania and throughout the nation from this very, very powerful synthetic fentanyl compound. And it gets even worse than that, because we have seen in Pennsylvania and in other states a compound called carfentanil. Carfentanil is actually an opioid anesthetic that has been designed for elephants, for veterinary use in zoos in elephants. But it's artificially produced and sold with to cut heroin, and that is 100 times more powerful than fentanyl. So if you do the math, it is up to 10,000 times more powerful than morphine, and is an extreme danger for use if someone suffers from the disease of addiction and is using those compounds, or even for first responders who might get it on their hands and could overdose. And that has happened a couple of times in Ohio and other contiguous states.
Mm-hmm. Doctor, you sit with the governor, Secretary of Health, and other policymakers. Where do we go in terms of public policy to confront this situation here in Pennsylvania? I'm sorry, but I know it's public policy from the administration, but also perhaps for the legislature to be aware of.
Absolutely. So thank you for that question. So Governor Wolf is committed to addressing the opioid crisis. It's really one of the priorities of the administration. And within the administration, it is really all hands on deck. It is all of the agencies working collaboratively together. And in addition to the administration, we are working hand in hand with the legislature on these issues. This is not a partisan issue in any way. And so we have had numerous legislative acts that the governor has signed over the last several years addressing this. We are also working with community partners and county partners. We're working throughout the state. We're working with other stakeholders, such as in the recovery community and in public health, as well as other states and in the federal government. This is also a collaboration between public health and public safety and law enforcement. Now, I'm going to emphasize the public health aspects. So there are a number of initiatives that we're working on, and the first is prevention. And so we want to prevent people from getting addicted to these compounds in the first place. And it's very important to remember that addiction is a disease. It is a medical condition. It is not a moral failing. But we want to prevent people from getting that. So one of the things we're doing is working on a program that I like to call opioid stewardship. Mm-hmm. And this was a term coined by Penn State Hershey Medical Center to describe efforts to work with physicians and other providers to use opioids much more carefully and judiciously. So opioids are really essential medicines in our medical toolbox. And if you're in a local hospital this morning with a broken leg, or you just had a significant operation this morning, or you have chronic pain such as chronic cancer pain or end-of-life pain, then we need to use opioid compounds. However, they have been overprescribed, as I was alluding to earlier, and we have to use them more carefully and judiciously. So we have a number of initiatives to accomplish this. We have worked with medical schools, the osteopathic and allopathic medical schools of the state, to develop a set of core competencies that every graduating medical student should have. And we'll be working with other healthcare schools as well, dental schools, nursing schools, etc., on their core competencies for their students. We have developed continuing medical education programs for physicians as well as other healthcare professionals such as dentists and nurses and nurse practitioners, etc. And they are available on professional society websites for free. That includes the Pennsylvania Medical Society, the Nursing Association, the Dental Association. We have developed 9 opioid prescribing guidelines, and these are location and specialty-specific prescribing guidelines. The most recent has been for orthopedics and sports medicine. They have all been taken to the respective boards of medicine and other professional boards for their consideration, affirmation, and acceptance. We're currently working on pediatric and adolescent guidelines and have further guidelines in the pipeline. In addition, Secretary of Health Karen Murphy has developed the Prescription Drug Monitoring Program. Now, this was an act of the legislature at the end of 2014 and implemented in August of 2016, where physicians and other prescribers have to check the statewide database before they write any prescription for an opioid or another set of medicines called benzodiazepines, to see if someone is getting multiple prescriptions and that person might suffer from the disease of addiction, and then refer them to treatment. Now, the next large initiative has been in rescue. We want to save people who might be overdosing, and that involves the medicine naloxone. Now, also, legislation passed at the end of 2014 allowed first responders to carry naloxone and allowed the public to have access to naloxone. Now, in 2015, as Physician General of the state, I signed 2 standing order prescriptions for the entire state. One was for the first responders. And in the last 2.5 years, first responders have saved 3,486 lives using naloxone. In addition, I signed a standing order for the state that anyone in the public can go to your pharmacy and obtain naloxone, either by nasal spray or auto-injector, that you could have at home in case you might have a loved one that might be at risk of overdosing, either from a prescription pain reliever or from heroin, might be suffering from the disease of addiction. And so we want to work to continue to increase this public access to this life-saving medicine. Now, naloxone is necessary, but not sufficient. After the person's resuscitated and revived from their overdose, we have to get them into treatment, and that is called a warm handoff. A warm handoff is a facilitated referral for treatment, and we want a firm warm handoff where a patient is referred directly to substance abuse treatment. And we have developed a warm handoff clinical pathway for emergency departments to use with the county drug and alcohol authorities. We call the single county authorities, to get people into treatment. And then finally, we're expanding treatment. We want to expand all aspects of treatment, including rehab, but we have been focusing on what is called medication-assisted treatment for patients suffering from the disease of addiction with opioids. And that includes uses of medicines such as methadone, Suboxone, or Vivitrol. And the governor has established 45 centers of excellence throughout the state for those type of treatment and that type of care. And we are working on some new initiatives with some money from the federal government to expand medication-assisted treatment in a quality way throughout the state. So we're very excited that we have what's called the 21st Century Cures Grant from the federal government to work on all of these different aspects: prevention, recovery, rescue, warm handoff, and treatment. Now, to have more access to naloxone, the governor has asked for $10 million in this year's budget to purchase more naloxone for the first responders. So we really have a collaborated effort with all of the agencies, working with the legislature and all of our community partners and all of our law enforcement partners to address this epidemic in our state.
Doctor, there's a strategy that is somewhat controversial. It's the safe sites where someone who is going to use a drug goes to a site where there's a medical professional there. What's your opinion on this, and what's your recommendation to the governor on this issue?
Mm-hmm. So you are correct. This is a controversial proposal to have safe sites. And now I know that Philadelphia is considering that proposal. The task force convened by the mayor of Philadelphia, that I was very pleased to participate in, has discussed that, and they're having further discussions in Philadelphia about the utility of safe sites. There is not much experience in the United States with this type of program. There is some experience in Europe, although there isn't much medical data on how successful that will be. So we are beginning to have those discussions in Harrisburg with the administration, and we'll see how it turns out. So we have not made a decision about those, and we'll wait and see what the mayor says in Philadelphia.
Doctor, I want to go back to prevention, but you know, you've worked all your life basically on pediatric medicine, adolescents.
Mm-hmm.
What prevention strategies can we work with for young people? You know, going back to the 80s when there was the Nancy Reagan just say no mantra that a lot of folks said, well, that really didn't work, it doesn't work. Based on your experience, what are some strategies that you feel comfortable with that can have, we know that nothing is 100% guaranteed, but that could be more successful than others?
I think you bring up a very important point, because we do want to emphasize prevention programs for young people, and particularly prevention programs in schools. Now, it is important to remember that the federal government used to support a robust effort for substance use, drug use prevention in schools, but much of that funding was cut. We are hoping to use some money from that 21st Century Cures grant to be able to expand the current programs in schools in Pennsylvania. But we need to do that in the context of other courses. So, for example, we need to use training programs. There's one training program called the Life Skills Training Program to embed it in the school curriculum and the school culture. Just a one-time lecture by someone about the evils of drug abuse, it doesn't always have the desired effect with young people. So what we need to do is to embed a program that teaches children not only the dangers of drug use, which certainly exist, but teach teenagers and other young people this in the context of resilience training. We need to teach them to be able to withstand peer pressure and other pressures about substance use and other difficulties that they might experience. And so that general type of program is called Life Skills Program. And so we'll be working to expand those type of programs in schools. Another type of program is called the Student Assistant Program, or the SAP programs. And there were very robust SAP programs funded by the federal government in decades past. Much of that funding was cut, and we're hoping to use some of the money from the 21st Century Cures grant to expand and enhance SAP programs, student assistance programs, where they might pick up a young person who might be struggling, and then we can hopefully prevent them from going down that road of substance use and addiction.
Doctor, women face special challenges, particularly if they're, have a strong addiction, but they have children. They might be single moms. Obviously, outpatient programs, they have access to, but residential programs, first of all, the number of beds for women is very limited in a county like like Lancaster. What are your strategies to try to look at the issue of women, their children, their families in context of this scenario?
So you are entirely correct. It's very important to be able to offer services to women in addition to men. Now, men have suffered from addiction more and have had more overdoses, but women have had a higher rate of increase over the last number of years. And many, unfortunately, many women suffer from the disease of addiction to opioids or other substances. So we do have to tailor treatment to women and to families. So there are some rehab programs that will actually take children with the mother, especially young children, into that program. But again, we have been emphasizing, at least for opioid use disorder, the importance of outpatient treatment with medication-assisted treatment. And that's what we've been working to expand with the Centers of Excellence and these new programs called Pennsylvania Coordinated Medication Assistant Programs that we'll be working on. And so that would provide women with access to this important medicine, but also combined with other treatments such as counseling. But much of that can be done on an outpatient basis. For women who do require inpatient, we have to make some provisions for their children.
Now, Doctor, I would imagine that would cost additional dollars. Where would those dollars come from? We are in a budget crunch, and the governor and the administration and the legislature are currently negotiating this year's budget, but there's a significant deficit. So we'll have to be very imaginative in terms of funding. One of the most exciting funding sources that I had mentioned is the 21st Century Cures grant. That is $26.5 million that we're receiving this year from the federal government to put towards prevention, rescue, warm handoff, and treatment. And we're hoping for further federal funding, and we'll have to be very
creative in terms of how we use money and where we're able to find funding. Now, I have to point out that one of the most advantageous acts that the governor did at the beginning of the administration to help patients with addiction is to expand Medicaid. So the governor expanded Medicaid right at the beginning of his administration in 2015, and that allowed 720,000 people to have access to quality medical care. And that includes approximately 120,000 people who've been able to access quality substance use treatment. And so it's extremely important that in terms of legislation that might be being discussed by Congress in Washington, that we don't roll back Medicaid, is that Medicaid coverage continues to be robust. And that is one of the dangers of the American Health Care Act that was passed by the Federal House of Representatives earlier this spring, and that's being considered by the administration. So we're hoping that the Senate will take a different tact and that we will continue to have Medicaid expansion under the Affordable Care Act so patients can have access to quality health care as well as quality substance use treatment. And that's for women, families, for men, for everyone.
Doctor, you mentioned that law enforcement is not your expertise, but in speaking to police chiefs, district attorneys, they say they can't arrest their way out of this predicament. What do you recommend to them? Well, what are some things that them and perhaps the courts as well?
Absolutely. So we network with public safety and law enforcement officers frequently. We were actually just at a meeting last week with the Attorney General's office. We have regular meetings with the Pennsylvania State Police, and we've had meetings with the DEA and the FBI. So public health needs to coordinate with public safety. But the law enforcement officers tell us that this is at its heart a public health issue. And it goes down to freshman economics. It is supply and demand. If the demand is sky high because of the problems we've been discussing, then it's going to be the heroin and other opioid compounds will be cheaper, and then it's very hard for public safety and law enforcement to strangle the supply. If we're able to bring down the demand through prevention efforts, then the price will go up, and they will be able to get a better handle through their law enforcement activities. And so we need to all work together on these issues. But this is we work with for instance, the Coroners Association. New data from 2016 indicate that there were 4,812 deaths in Pennsylvania in 2016, which is a significant increase from 2015. The data from Lancaster indicates that there were 117 deaths in Lancaster County in 2016, and that's up from 80 a day in 2015. We had been saying that 10 Pennsylvanians die a day from overdose. Now it's 13 Pennsylvanians a day. So we all need to work together, and public health needs to work with public safety to address this. And so we'll be working with them on prevention efforts, on rescue efforts, as we have with law enforcement with naloxone, on working with getting people into treatment with them, for instance, in drug courts. There's money in the 21st Century Grant to support drug courts. Drug courts are a very good way to make sure that a patient stays in treatment with perhaps criminal prosecution if they don't. And so drug courts have been very effective, and we support their further support and enhancement.
Doctor, how do you respond to some folks who say, this person has been revived with naloxone 3-4 times? Are we wasting our money or what?
So I just disagree with that in the strongest terms. I feel that all of life is sacred in that everybody deserves a chance for life. And everyone deserves a chance to be resuscitated and revived with naloxone because, again, addiction is a medical condition. It is not a moral failing. So let's think about someone who might have had a second heart attack. We don't sit there and discuss whether we should revive someone from their second or third heart attack, whether they were taking their medicine correctly or eating the right diet. We resuscitate them, and then we try even harder to get them into treatment. So it's very clear in terms of naloxone that a patient can't get into treatment and into recovery if they're dead. And so all naloxone does is revive someone, and everyone deserves a chance at being revived and to get into treatment and hopefully a recovery. But we do need to redouble our efforts on that warm handoff program and other efforts to get people into substance abuse treatment so we do not have these recurrent overdoses requiring naloxone. And so we do understand the pain and suffering of families who might see that, of the first responders, of our healthcare professionals in emergency departments. And so we are working on various ways to enhance the warm handoff into treatment and try to make sure those patients have every opportunity to get into recovery.
Part of the team that I think isn't real clear what role they can play is the average person, a neighborhood group, a block association. What do you recommend to those entities to be a part of the team to confront the situation?
Well, I think that community work is absolutely essential. This cannot just be done by the state or the federal government. We need to work with our counties and our communities at the local level, and that's often where change will be seen. So we need to work with communities on drug abuse prevention, to try to get heroin off the streets, to work with law enforcement on that. I think it's very helpful if the public has naloxone. Naloxone, again, can be obtained based upon my prescription. You just have to walk into a pharmacy and ask for it. Medicaid will pay for naloxone, and most commercial insurance companies will cover it, perhaps with a copay. So that if you see someone who's overdosed, I mean, I carry naloxone in my purse, so that if you see someone who might be overdosed, that you could revive them with a nasal spray or an auto-injector of naloxone. And then we need to continue to work on enhancing that referral, that warm handoff, and expanding treatment within communities themselves. So I think as communities band together, that they can be effective. For example, in northern Pennsylvania, there's a program called Project Bald Eagle, which has made, in north central Pennsylvania, which has made great strides. And there are other community groups and task forces that have been working on this. I know that York County has a task force, and I believe Lancaster County has a task force. So I think that community action is absolutely essential.
Well, Doctor, I want to thank you for being with us this morning on Think It Over. We have spoken today with Dr. Rachel Levine, Physician General of the Commonwealth of Pennsylvania. Thank you, Doctor, and have a great day.